Hi, everyone. My name is Dr. Gail Roboz. I'm a professor of medicine and director of the leukemia program at Weill Cornell Medicine and the New York Presbyterian Hospital in New York City. I would like to thank the organizers very much for the invitation to this meeting. I actually wish I could be there in person. I have not traveled to the area before, but I look forward to coming in the future and to hopefully using this meeting as a stepping stone to have some collaborations between our countries and our institutions. I have been given two topics for this meeting. The first one is advanced therapeutics in AML. Are we moving forward? These are my disclosures. And the answer to the question is a very resounding yes. And since the organizers and the initiators of SOHO are Dr. Kantarjian and MD Anderson, I would like to show as evidence for the yes answer to my question, their data actually of the overall survival of patients with de novo AML treated at MD Anderson over the past 5 decades. And it's very clear here that if you look at the patients under 60 on the top and over 60 on the bottom, we are certainly making progress. Clearly, as is well known, the younger patients are doing better still than older ones, but even among patients older than 60, where for many decades there were almost indistinguishable survival curves, we are finally doing a bit better. And why is that? So it used to be in past decades that actually when there were any improvements at all in AML, it was really attributed only to better supportive care, better antifungals, better access to transfusions. But actually, especially in the last decade, there is better science, better understanding of the biology of the disease, better treatments, and more approved therapies. There are also more transplants being done for patients across the ages and across different donor types, and they're safer. And all of this has resulted in the improvements that we can see. That optimistic view, of course, is still not meaning that we're done. There's plenty of room, as you can see on these curves, for much more improvement. So if you look at the SEER statistics, you can see that the cases of AML are about flat. They're about 20,000 per year. They don't seem to be rising dramatically, although they are perhaps creeping up. But the percent surviving 5 years overall, not only at MD Anderson, but overall has actually also gone up. And you can see in the bottom right, there is a steady improvement in overall survival. But if you look at the top part of this slide, which shows actually the incidence of AML compared to other cancers, you can see that this is still considered a rare disease. This is not breast or prostate or lung cancer, which are measured in hundreds of thousands of cases. We've learned over the last decade that this is a biologically diverse malignancy. So AML is not one disease. And if you're a fellow and you have to memorize all of this for the boards, you're sad because there are very different behaviors of the biological subsets of disease. And it's actually become mandatory as part of the diagnosis to have a combination of next generation sequencing data as well as karyotypic information. And this really results in lots of different, as you can see, sections of the pie. So the good news is that this is resulting in the ability to target some of these subtypes separately. But the bad news is, and I'm going to discuss this a little bit in my second talk at SOHO about real world evidence, that it becomes very difficult actually to generate data for every single subtype that's in here. And there are subtypes of AML that behave in a distinctly different manner from each other. And I'm going to talk about that a little bit. So you can see here that if you take, for example, the ELN 2022, the European Leukemia Net Risk Classification, this is a combination of molecular genetic information and cytogenetic information. And a lot of this is still, or if you go around the world, difficult to access from different countries. Many places it's very tough actually to get cytogenetic data back. It might take a couple of weeks. FISH, for example, might be faster. And molecular genetic information is not available everywhere. But as you can see here from these curves, the combination of this information results in very, very different predictions about overall survival. A couple of important points. Number one, all of this is dependent on available treatments. You can notice, for example, that FLT3 ITD has been moved over the years out of the adverse categories and into the intermediate ones because of the availability of FLT3 inhibitors. So again, this is is not a static picture. This really depends on the overall treatment landscape, what these survival curves are going to look like. But basically, the intermediate group is largely transplanted in first remission for younger patients. The green group on top, the favorable ones, which does include APL, which is a different lecture, but also core binding factor disease. These patients are typically not transplanted in first remission. And of course, the orange and red people on the bottom are doing still poorly with adverse karyotype, complex karyotypes, and of course, TP53 being the most difficult of all. So if you look at the diagnosis of AML, not only is it complicated because of the need for both karyotypic and next generation sequencing data, but actually even the line in the sand that used to be drawn for blast count is now being questioned. So it used to be back in the day that 30% blasts on an aspirate was AML, then it was dropped down to 20%, and now even that is in question because, for example, like TP53 mutated diseases, does it really matter if you have 11% blasts or 21? Nope, the biology is the same, but this is very confusing for doctors and for patients because now it looks like, depending on the classification, that anything over 10% blasts can be considered AML or this potential hybrid category of MDS AML. So I won't spend a ton of time on classification, but basically to realize that blast count is not as important as it used to be. There is not a line in the sand for blast count, and it's really the combination of molecular genetic and cytogenetic data that is going to guide all of your therapeutic decision making. And not only that, you have to think about what the disease is doing at the beginning, the middle, and the end of its course. We know that there can be mutational complexity at diagnosis, clonal evolution, and then actually increasing genetic and epigenetic heterogeneity with relapse. And what this means is that in terms of the patient journey, there are times when a patient is in remission where we are going to be looking, for example, at MRD, measurable residual disease, to see what is left over after the initial therapy. We know that when patients are relapsing, they may have changed their mutational profile, so this needs to be checked again. And I think if you just remember this picture, to remember that this is a dynamic state of affairs, and what the patient has right at the beginning of diagnosis has to be reevaluated throughout their treatment course. Now, the treatment course is still what everyone remembers. You somehow get the patient into remission with what is generally termed either intensive or non-intensive approaches. Then you do some consolidation, which is either ongoing therapy, chemotherapy, or typically an allogeneic stem cell transplant. We don't do much auto transplant in the United States, but across Europe, sometimes they do. And then maintenance therapy, even after transplant, but certainly after chemotherapy, has become standard of care. Now, if you look at the US and the EU drug approvals for the last several years, you can see that we are doing much better than we used to. There are multiple drugs on this list. There are targeted drugs, including against FLT3, IDH. There is, of course, a revolution in therapy with the BCL2 inhibitor, venetoclax, and all of these together have resulted in a much more complex treatment landscape than what we had even just 10 years ago. And this treatment landscape is resulting in more and more complicated slides like this, where it kind of used to be simple that if you were strong, you got 7 and 3, and if you were weak, you got a hypomethylating agent and low-dose cytarabine. And those backbones are still very important in planning your treatment. But once you've assessed the patient and done all of the comprehensive profiling that I discussed initially, what we really are trying to do is that for patients getting intensive chemotherapy, what are we adding to those therapies? Are you adding gemtuzumab? Are you adding a FLT3 inhibitor? Are you adding IDH inhibitors? On the other side, in the red, are patients who are initially ineligible for intensive chemotherapy. What are they getting? Maybe they're also getting FLT3 inhibitors or IDH inhibitors that are added on to less intensive backbones. And then everything at the bottom can go to the purple, to stem cell transplant. You have patients who are initially not considered eligible for intensive chemotherapy who are going on to transplant. And then, of course, on the eligible side, most of those patients in the intermediate and adverse categories are still going on to transplant. TP53 is a whole separate category that unfortunately we still don't have good options for those patients and are anxious to have medications that actually work. So to go through some therapy, 7 and 3 or cytarabine and daunorubicin are the basics. What can we do to make those better? So over time, we've done a couple of things. First, there was a liposome. CPX351 is a liposome with a fixed combination of cytarabine and daunorubicin. This was, again, in the spirit of optimizing 7 and 3. This was tested in a randomized trial. If you look here, it was CPX versus standard 7 and 3 with a primary endpoint of overall survival. And actually, this was tested in treatment-naive patients who were 60 to 75 years old with therapy-related or secondary AML. This resulted in an improvement in CR and in overall survival, and this has resulted in a standard for those patients, although the classification of those patients has now become a little bit more complicated since therapy-related and secondary disease is a little bit less clear than what it used to be. That said, this is an improvement in 7 and 3, and this has become part of the standard of care. What else can we do to 7 and 3 to make it better? Well, gemtuzumab, which is an antibody conjugated to, it's an anti-CD33 antibody conjugated to calicheamycin, was originally approved years ago for relapse disease, but then was actually brought back. And in the Alpha 0701 France trial, this was a combination of a fractionated schedule of gemtuzumab with 7 and 3 versus 7 and 3 alone. And again, what was this trying to do? Make 7 and 3 better. And it did. This was an event-free survival primary endpoint, but you can see that there was an improvement. This improvement for gemtuzumab was done in a different schedule, a lower dose fractionated schedule than what had been initially approved many years ago. And you can see in these curves that the primary benefit is in favorable risk patients where there is quite a dramatic overall survival improvement. This has become part of the standard of care for patients with core binding factor AML, inversion 16, 821 AML. It is of less obvious benefit in intermediate risk or adverse risk. But again, in many parts of the world, it's difficult to get that risk stratification information up front, so the drug was made available for all patients so that those who would benefit would not suffer. That said, it's clear that in the adverse risk, it's not adding anything, and in intermediate risk, it's debatable. Many parts of the world do use it as standard of care even for intermediate risk, but certainly for favorable, the overall survival benefit is clear. Now, what else can we add to 7 and 3 to make it better? Well, the age of targeted therapy was launched with FLT3 inhibitors. There are several different FLT3 inhibitors that have been and are currently undergoing testing. There are 2 types. This is important because the type 1s are active on both the ITD and the TKDs, whereas the type 2 are active on ITD mutations only. So it's a bit important to keep your inhibitors straight in your mind. But basically, there have been 2 large randomized trials. The Ratify was the original randomized trial that ushered in the age of targeted FLT3 therapy with midostaurin versus placebo, having an overall survival benefit. This included both ITD and TKD patients, and more recently, the Quantum First trial of quizartinib also resulted in a survival benefit and the approval of this agent. So we now have 2 inhibitors that can be added to 7 and 3 that result in an overall survival benefit, and this is part of the standard of care for these diseases. We can further intensify standard chemotherapy, and of course, MD Anderson has piloted even more intensive than 7 and 3 regimens. These are regimens that use intermediate doses of cytarabine upfront, the FLAG-IDA regimen, and also CLIO, which is a combination of cladribine and intermediate dose cytarabine, have been intensively used at MD Anderson with great remission rates, and the addition of venetoclax to these regimens makes them even more powerful. These are not randomized data versus other intensive therapies, but certainly at MD Anderson and also at many centers, including ours, for particularly fit younger patients, we often will use this sort of maximally intensive induction. It is tricky, though. I would be careful to have experience with it and a good intensive care unit if you're going to try to use these. They do have significant toxicities to be aware of, but the overall survival curves look incredibly promising, and the MRD negative remissions as well. Now, once you were done with getting a patient into remission, we know from 2009 that there was a benefit to getting people into transplant as soon as possible, certainly for the intermediate and the adverse risk categories, and we typically do try to do this. But even after transplant, which you were supposed to be cured and done, we see, for example, that even after transplant for FLT3 mutated patients, there is a benefit of maintenance, in this case with sorafenib beating placebo, and more recently, the Morpho trial, which looked at the benefit or potential benefit of gilteritinib, a novel FLT3 inhibitor, after transplant. So these patients were randomized even after transplant to get ongoing therapy with gilteritinib. This initially looked like it was a negative trial in the primary objective, but of relapse-free survival. But if you look carefully here at the data for MRD positive versus MRD negative patients, I'm showing this because this is how the needle is moving forward in AML therapy, that we now have MRD testing, which is in this case a dual modality PCR NGS MRD test for patients with FLT3 mutated disease, that if you have access to this test and you have a patient who has a FLT3 mutation, who's MRD positive after transplant, there is a clear benefit for gilteritinib. So I think this is ushering in a new era of how to decide which patients should get ongoing maintenance, even in the post-transplant setting. But the median age of AML is older. Does this really cure people who are older than 70? These are newly presented data from June 2023 that show an overall survival of 48% for patients over 70. Definitely better than what we used to do, but not what the patient has in mind when they're going forward for curative therapy with a transplant. They are thinking they're going to be cured at 5 years, not having 2-year overall survival of 48%. And in addition, you want to be looking at graft versus host disease free overall survival, which, as you can see here, is only 33%. So there's still a lot of toxicity for transplant for older patients. So what else can we do? The Quasar trial, which took forever to get done, but looked at patients over 55 who couldn't go on to a transplant for whatever reason and got randomized to oral azacitidine versus placebo. And this trial actually showed an overall survival benefit for oral azacitidine. Again, these are patients who couldn't go on to transplant, but who are very high risk of relapse. So if you have patients in that category, this is definitely an agent to consider. And we saw that even for those who were flow cytometry positive at the end of their chemotherapy treatment, and these are patients with a very high risk of relapsing, you could see that in particular for the overall, for the MRD positive patients, there was a benefit for oral azacitidine. So this can be considered, again, in transplant ineligible patients. We also looked at quality of life for these patients, and although all medications have side effects, and this one does too, it is possible to maintain patients with an excellent quality of life on long-term therapy with oral azacitidine. Now, oral azacitidine is a different world. That was talking about maintenance after chemotherapy. Here we have injectable azacitidine combined with the BCL2 inhibitor venetoclax, which totally changed the world of treating older patients and chemo-ineligible patients by having a very clear survival benefit that spanned cytogenetic and molecular subgroups. So this has become the worldwide standard of care for, again, patients who aren't getting intensive chemo up front. And you can see that this overall survival benefit has persisted, and it's not curing people at 5 years, but it's much better than where we were. So what else has been happening in the space of older patients and less fit patients? We looked at ivosidenib, which is an IDH1 inhibitor, and this actually had single agent, as a single agent pill, some durable, nice CRs in patients. So the question became, what can be done with the inhibitor in various combinations? And the AGILE trial, again, looking at ivosidenib versus azacitidine versus placebo and aza in newly diagnosed IDH1 mutated patients, showed some very competitive data even to venetoclax. So here we have a subgroup of patients with an IDH1 mutation who actually have a choice. They could get ivo and aza, or they could get venetoclax and azacitidine, depending again on what's available and what the clinical circumstances are. The point is to show, though, that we are building even on the so-called low-intensity regimens by adding different things. And here, for example, we have an emerging triplet therapy of venetoclax and azacitidine and the FLT3 inhibitor gilteritinib, which look like promising data both in terms of CR and overall survival. And we're hoping that there will be randomized data available, hopefully, to prove that this triplet is worthwhile to go forward. Venetoclax and azacitidine can also be combined with IDH inhibitors, and these are not randomized data, but it pushing the envelope of how do you drive the remission rate to some of these older and less fit patients to rival the remission rates and maybe even eventually overall survival that would be achieved with intensive chemotherapy. We're not there yet, but these are interesting early data. And coming soon are the menin inhibitors. So looking at KMT2A and NPM1 mutated patients, the menin pathway is a very powerful one, and there are several menin inhibitors that are being combined both with intensive and non-intensive chemotherapy to try to see if we can get these KMT2A and NPM1 mutated patients their own targeted triplet type of therapy. Now, in relapse disease, these are old data from 2014 showing that everything that we had at that time looked the same, whether it was chemotherapy combinations or novel agents. We weren't doing very well, and relapse disease is continuing to be very, very difficult and usually, unfortunately, not curable. But a couple of quick points. The first thing is back to what I said at the beginning, to repeat your molecular data, because if the patient pops out a FLT3 mutation or an IDH mutation, you could potentially have targeted options for those patients. Pummeling patients with relapse disease who have FLT3 mutations or IDH mutations with additional chemotherapy is probably not going to work. So you want to look for those additional opportunities for targeted therapy. And then we have an emerging trial, which is an interesting one called the Sierra trial, which is an anti-CD45 monoclonal combined with a beta emitter. And here the randomization was to look at IOMAB versus a conventional approach of pounding the patient with additional chemotherapy. This was actually a positive trial. We're seeing what will happen as this goes forward in the approval process, but this combined with some data coming from Germany suggesting that many, many rounds of additional chemotherapy for relapse patients is just not helpful, will hopefully usher in some better options for our patients with relapse disease. Of course, the hope is for no one with AML to relapse, and then we won't need to use anything for relapse disease, but we are unfortunately not close to that yet. This is what my hospital looks like at night in New York. These are my wonderful colleagues, and I would like to thank you very much again for the invitation to be here for this presentation.